Good. So I'm operating on very poor sleep and a head cold that's pretty brutal. But I was surprised with my findings with you yesterday. One of which was that you do have a little bit of laxity in this right knee that you were unaware of. And I'll just point it out. And there's a little bit of play there, as though the ACL ligament is injured. But there are times when we've been able to reduce reflex inhibition of the secondary stabilizers and have that change. So my hope is that that's not a true injury, meaning a true significant ligamentous injury.
Right.
Okay? But the most fascinating thing is the evaluation of the pelvis, if you would lie on your back. So yesterday when I evaluated, I was very surprised. I didn't expect to see this. And when I put force through your pelvis, I can induce kind of a normative movement that I would expect to have. And I'm taking up the slack in the structure, and the movement is taken up in various proximal regions. And now when I spring through the pelvis, it moves. But when I let go, it is so slow to recoil. That's a sign of hypermobility. On the other side, it has a very similar effect. I push until it stops moving, and I hold it there, spring it, and it just doesn't recoil. I let go, and it just comes back slowly. Remarkably surprising. Okay? Can I have you lie on your stomach, please? When I do a superior glide test through the left hemipelvis, take up the slack through the ischium, spring it, and again, there's no recoil. There's this slow return. When I do an inferior glide, take up the slack to an end point, thrust it, and it thrusts forward, but it comes back so slowly. It's very surprising. When I take up the slack, spring on the sacrum and come off it, there's not that usual comeback sensation, that recoil. Sacrotuberous ligament is right here. It's ill-defined. It's hard for me to locate it, okay? That should be it right there. And if I push on it, it goes so deep. So what we have is a sloppy pelvic structure. So I think that there's a tremendous amount of inhibition. And because everything is lax, I'm speculating on a certain pattern in her pelvis that when she got injured, that the sacrum got pressed forward. Now, part of the exam yesterday included checking the pubic structure in the front, and I felt that there was a divot. She was tender there, and you had the same sensation of not being able to perceive a recoil when we loaded it and applied a very small anterior to posterior spring through that bone. Do you have anything to add to that? Mm-hmm. So it's a very surprising finding that this pelvic structure appears to be very hypermobile in a body that's otherwise very strong and very accustomed to being very, very physical in the world. So what we're going to do is stop filming, except now as don't stop yet, because all of a sudden the little brain cells are kicking in, and I did not sleep at all last night. Flight was horrible, 4-hour delay. Anyway, I also went to your neck, and I went to your sternum as well, and that's what I want to point out. So could we have you lie with your head down here, please? And this is the opposite of a pattern in which the sacrum appears to get wedged posteriorly, and it locks up all movement throughout the pelvis, and the person hyperextends at T3, T4, upper body of the sternum becomes very rigid, same thing with rib number 3 on both sides, T3, T4, and their upper cervical becomes very tight. And just this is just a theory, it's just a model, but if the sacrum goes posterior through a trauma, like a fall on both buttocks, things open quickly and a forward flex trunk pushes it, wedges it back, etc., then it stands to reason that they would have to hyperextend to counteract that posterior displacement of the center of mass. And it seems to me that they hyperextend here, and then the last is reserved for up here. We are the opposite of that pattern, where sacrum seems to have moved forward into the body and created laxity. And so when I was testing up here, we found that when we got to the upper body of her sternum, That's a little extra movement. What does that feel like to you?
To me, like when you do that, this is the second time today, it doesn't hurt, but to me, it feels stuck.
Interesting.
But when you do it, you can feel so much more movement, so it's really interesting that my perception is so different from what it is.
So you perceive that there's something
I
amiss.
perceive limited movement.
This feels strong. This feels excessive.
Yeah.
Excuse me.
Bless you.
Keep filming. Okay, so now we're going to just look at a very simple traction test on the upper cervical. And I want to take up the slack in your upper cervical, and it travels a lot. And then I pull it, travels, and when I pull it and let go, it doesn't recoil with integrity. I take up the slack on this part to an end point, and now I'm going to traction it, and I'm going to let go, and it just doesn't suck back into your neck, if you will. It sounds a little frightening. Yesterday it felt a little more rubbery than it does now, but what I'm suggesting is that even up here you have some laxity, and this is reflexively connected to this, which is reflexively connected to the pelvis. So this is all speculation. Let's stop here, and let's treat this and see if it's a mutable property, okay? Thank you.